will present the way to get the maximum of stem cells during bone marrow aspiration. As has been explained previously, the current way to get cells at this moment is bone marrow aspiration and after concentration. But remember one thing, you can concentrate only the cells you have obtained by aspiration. If you are not able to get the cells by aspiration, you concentrate nothing. So the first way, of course, is to obtain some cells with aspiration. It's simple from a theoretical point of view, but it means that you understand something if you want to have the cells. It's exactly like fishing in a lake. You have many bodies trying to fish and, around the lake, but only some of them are able to take some fish. So it's the same for the bone marrow aspiration. If you don't keep in mind some rules, you will not be able to have cells. First, just an explanation about the iliac wing. The most important part of the body to get the cells is the iliac wing. It's a spongious bone, as you see here, and it's not homogeneous. We will see later about the anatomy of the iliac wing. But remember that the cellularity of the marrow is not the same everywhere. And for example, if you look at the active bone marrow, the marrow cellularity, the first is the wing, the iliac wing, because you have 17% of active marrow by mass. If you compare, for example, the proximal femur or the proximal humerus is clearly lower, and after the iliac wing of the iliac crest, the second is the ribs, and the third is the sternum. But other parts, of course, is the lumbar spine also, and the thoracic spine. But the other parts, as the distal bones, have clearly less marrow cellularity to get the MSC. Remember also one thing, that the composition of the bone marrow for stroma cells, there is only one stroma cells for 250,000 cells. So there are not so many MSC. And as compared, the hematologic cells are clearly more numerous. The points that are very important is the way to use the needle and the aspiration and the syringe. First, you have to be able to introduce your needle or your trocar for aspiration between the two tables of the iliac wing. So you have to enter in the iliac crest, and the trocar should remain during aspiration between the two tables. If you go outside, of course, you create a hole, and you are not able to aspirate the bone marrow, and even you go back, you will not be the same, because you will have not the same force of void during the aspiration. I try to. And the first way is to introduce the. Does it work? Oh, yes, it works. Sorry. So the first way, the first thing is to introduce your trocar, and you have to put the two fingers on each side of the iliac crest, and you enter the trocar between the two tables, and after you put the syringe for the aspiration. And you lock your trocar on the syringe, and when you lock your trocar, you have to create a force, create a large force of aspiration, and the bone marrow is going inside the syringe. Remember that the direction of the trocar is in relation with the anatomy of the iliac wing. Of course, this is the anterior part. This is the posterior part. You have to direct the trocar in direction of the hip, of the center of the iliac wing. You go in this direction if you are in the anterior part, and we will see later, if you are in the posterior part, you go, of course, in this direction. So and you can aspirate, of course, here in this part also, because it's thickness is correct, and of course you can also aspirate, sorry, on the posterior part. And if you see the iliac wing in this situation, of course, it's thin. And you have to keep in mind this particularity. And keep in mind also that the posterior part is thicker than the anterior part. This is the anterior part. And if you check now the posterior part, you see that the middle part is very thin, but the posterior part here is thicker. So it's easier. If you begin for bone marrow aspiration, perhaps it's easier to begin by the posterior part because it's thicker. But the patient has to be on a lateral position or a propulsive position. And for aspiration, remember that, of course, you have to change every time you have get 4 cc or 5 cc. You put a new syringe and a new aspiration. And you force the aspiration. It's quite quick to have an aspiration and to change the syringe. It takes only 10 seconds if you have clever and you create a channel in the inside the marrow to do the aspiration. And so keep in mind also that the channels have to be parallel. If you cross the channels, of course, you will cross your channels and you will aspirate the void, or you will aspirate the other hole. So you have to keep the different channels parallel to avoid to entry in another channel. We use usually a 10 cc syringe. It's a small syringe. I will describe. And remark this, when you have a great force of aspiration, you have bubbles in the syringe. The fact that you have bubbles means that you have created a large force of aspiration, and this large force of aspirations mean you will get the MSC. I will explain why later. So just look about the aspect of the aspiration. Bubbles is a very good sign of a large void of aspiration and probably a large number of MSC. And so, look, you have to keep this void force of aspiration, and when you look about some bubbles and voids, and you feel 2 or 4 cc, and after you change the syringe, and you remember that after you pull the syringe and the bone marrow in the bag, and between, of course, 2 aspiration, keep in mind that you have to rinse. We rinse the syringe with some dilution of heparin solution to avoid a clot. A clot is a problem because if you get too much clot, of course, it will be difficult after to get the MSC. And remember also that usually we put that in a bag, and at each time we avoid the clot by mixing the blood marrow in the bag. So, and when you do the channel, you can stop at every 1 centimeter for aspiration, and you can also continue to process in the same channel. So you can do a channel of 10 centimeters depth and do aspiration at 2 centimeter level, and after go back at 4 centimeter level and do another aspiration. So in the same channel, you can do 2 or 3 aspirations. And remember also that you have a curvature of the iliac crest, so keep in mind to direct usually your needle to the center of the area of the hip, and to keep also the channels in a way that are parallel. Don't do like this or like this, because you will cross the channel, and of course, you will now have void of aspiration, because if you cross the channel, you will aspirate not the bone marrow, but directly the air outside the iliac wing. If you have some assistant with you, you can do at the same time bone marrow aspiration from the both iliac crest. It's very convenient because you get, of course, more bone marrow and a quicker volume of marrow by doing aspiration in the both iliac crest, but that means that you are two people for doing the aspiration. So what about the syringe? The syringe is very important because the volume of the syringe is directly active about the void of aspirations. If you use a large syringe, you have not enough void, and you will not be able to get MSC. And each time you have to rinse the syringe, and just use a small syringe to get, usually the best is a 10 cc syringe. 20 is available, but not as good, and 50 syringe should be clearly avoided because you have not force enough to create a void of aspirations. This is the results we obtain by comparing a 10 cc syringe and a 50 cc syringe. You can remark that a 50 cc syringe, you get a low number of MSC as compared by using a small syringe, a 10 cc syringe. This is directly in relation with the shape of the syringe, and it's difficult to create in a large syringe force of aspiration. In a small syringe, you create a real force of aspiration. Remember that in the bone marrow, the MSC or the pericytes are stick to the bone because it's not elastic vessels. It's vessels in a bone, and the wall of the vessel is stick to the bone. So if you want to create disruption of the wall of the vessel and get the pericytes of the MSC, you need to create sufficient force of aspiration. If you have a small force of aspiration, you will get blood, but not MSC. And you will have, of course, dilution of the MSC with the blood. This is another example of the number of MSC you get with a 50 cc syringe and a 10 cc syringe as regard as you fill the syringe or not. For example, if you begin with a 50 cc syringe, you have no MSC. It's rather blood. And if you use a 10 cc syringe, you can remark that most of the MSC are, when you have 20%, means the 2 cc. For the first 2 cc, you have most of the MSC. 4 cc, you get more MSC, but between 4 cc and 10 cc, if you fill the syringe, you decrease the number of MSC you get. So the best way is to fill the syringe in half, I will say 4 cc, and after just change the syringe and come again to a new aspiration and so on. It takes some time, of course, but it's the only way to get MSC. If you use a large syringe and do an aspiration without void, you get only blood and you have no MSC in blood. So after you can concentrate, but you have nothing at the end. So keep this in mind, it's very important. You can discuss about the best choice about to get the cells. Is it the anterior part? Is it the posterior part of the iliac wing? But anyway, you don't know because it's not homogeneous, as you can see. And I will say that in my experience, it's the same as regard as the anterior or the posterior part. For example, in this iliac wing, you have more fat in the posterior part as regard as the anterior part. But anyway, you have to change to do several channels, 3 or 4, and go in several areas, so you are certain to get MSC. Don't remain in the same area because there is a risk. For example, if you aspirate here, you have rather fat than bone marrow, and you continue to aspirate at the same location, of course, there is a risk that you are not in the good area. If you change, you have, of course, a major chance to get the cells. So you can discuss also about the number of aspiration. You can do 10 aspiration of 2 milliliter, 10 aspiration of 4 milliliter, and so on. Remember that the best is 2 milliliter aspiration. But if you do only 2 milliliter aspiration, it's time consuming. And of course, it takes time in the operating room. So I will say that probably the best is to use 4 cc aspiration. With 4 cc aspiration 10 times, you have 40 cc. If you want more, you can do 4 cc and 20 times, and so on. So the best ratio as regards the number of MSC and the time consuming is the aspiration of 4 milliliter. And of course, if you have time, and if you have just a small volume, if you have just want to graft a small bone like a scaphoid, of course, it's better to do only 2 milliliter aspiration, and 10 times will be enough. Remember also that you have to have some knowledge of the anatomy of the iliac wing, because it's not a perfect regular bone, and there are some tricks to know about, to get the aspiration. And this is the iliac wing for a cut. But look about the iliac wing. So you have different iliac wings. For example, this iliac wing is very simple. It's easy to go inside the 2 tables and go straight to do the aspiration, no problem. Now, if you look about this one, it's more difficult because you enter this point, and the thickness of the iliac wing at this area is so thin that your trocar will go outside and will not be able to aspirate. So if you sometimes when you enter your trocar and you feel that you go outside, so change the location, go more anterior or go more posterior, but don't remain because that means that the iliac wing is very thin and you will not be able probably to get the cells here. This iliac wing is more disturbing because you enter here and after it's very thin. So you have to, if you want to get bone marrow, you have to enter here and go like this way and re-enter a second time in the deeper in this part. So it's not the iliac wing of each patient is not the same, and you have variation in the shape as you have variations in the noise or in the ears or the shapes. So 2 iliac wings are not the same. Sometimes you have a chance to have MRI of this patient because they have pathology like osteonecrosis. Look also about the cellularity. It's not the same. Some iliac wings have a high degree of cellularity. This is a patient with sickle cell disease. Other patients, this is a corticosteroid patient, have a low number of MSC probably because it's the bone marrow is white, and that means that a low cellularity of the bone marrow. And this is heterogeneous because you have parts that are white and some parts that are black. That means different cellularity. We look about the way to better know the anatomy of the iliac wing, because you have to remember that it's not the same anatomy for each patient. And for example, we develop a system of sectors. When you look about the iliac wing, you can look about six sectors, and you can report on the patient anatomy. One is the anterior part, and 5, 6 the posterior part. And if we have looked about CT scan of many patients to know the anatomy, and it's a regular situation that in the center of the iliac wing, the thickness is very thin. It's sometimes there is no bone, but always in the posterior part and always in the anterior part, you have no problem to get the cells. And this is important to know. So you have to decide if you want to do aspiration from the anterior part or posterior part. It depends of the surgery you do. It depends of the patient. If you are the patient in a supine position, of course, the anterior part is more suitable for the aspiration, but it's easy also to get bone marrow from the anterior part. But you have to keep in mind not in the middle part. The middle part is more difficult because it's very thin, and you will have some difficulty to enter between the two tables. This is when you look about CT scan. This is you have of course the bone thickness, the cortical thickness, and the bone marrow. Remember that the bone marrow, the volume of the bone marrow is less than the volume of bone because you have no bone marrow inside the cortex. And it's just in the center. So when you remove by imaging the cortical thickness and you keep the volume of bone marrow, keep in mind also that the volume of bone marrow of the iliac wing is not so large. It depends, of course, of the size of the patient, and it's around between 100 and 150, depending of the size of the patient. So it's keep in mind 120 cc of bone marrow. That means when you aspirate in iliac wing 100 cc of bone marrow, probably you have not aspirate all the bone marrow and you have blood dilution because you are not able to aspirate all the bone marrow. So keep this in mind. So you have, as you increase the volume of bone marrow you aspirate, you have the higher risk of dilution. That's the reason that you have to keep in mind to aspirate small fraction, 2 or 4 cc each time, and it's better than to aspirate a large volume with a large syringe at the same time. You have also some risk, like in surgery. The risk 0 does not exist. And remember that you have vessels close to the iliac wing, arteries, and also nerves. And sometimes we look about for residents how they were able to keep it and to remain inside the two tables. You can see that sometimes that each yellow point that means that a resident has done a hole in this area. So keep in mind that, for example, the posterior part, they have not so much holes, so it's easy. The risk is that the posterior part, you should keep in mind that the distance between the cortex and the sciatic area is just 6 centimeters. So you can enter in this part your needle 10 centimeters depth, but in this part only 5 or 6 centimeters. You may have a risk for the sciatic nerve. But if you check the middle here, you have higher risk to create a hole and not to remain between the two tables. You can look also on this aspect of the X-rays in some patients, and sometimes when you have done aspiration and create a hole, you have bone marrow leaking out of the iliac wing and making some ossifications. That, if you look at this picture, you can imagine the powerful possibility of osteogenesis of the bone marrow. Just by leaking bone marrow in the muscles after bone marrow aspiration, you are able to observe bone formation. Remember that the posterior part is easier because it's thicker, but you have risk. The sciatic nerves and the vessels are very close, only from this point to this point 6 centimeters, and from this point to this point 10 centimeters. So keep in mind, posterior part easier because it's thick, but keep attention, the needle has to be at the depth less than 5 centimeters if you want to be secure. And you can, of course, have patients with abnormal vessels. And this, sometimes you have abnormal vascularization. So this is the reason you have to keep in mind that to remain between the two tables for bone marrow aspiration. You have also some nerves, and the most important nerve for anterior aspiration is the femoral cutaneous nerve. It's a small nerve that is here and keeps, and this nerve gives the sensibility of the anterior part of the thighs. And if the problem is that these nerves have many variations, and it's 1% he crossed to the iliac wing, and in 9%, it may be between this point, the anterior iliac spine, and 2 centimeters. So keep in mind that this in 10% of the cases, the femoral cutaneous nerve has some anatomical variations. So if you want to be secure with this nerve, you have to do the palpation of the anterior iliac spine here on the iliac crest and move just 2 centimeters back posterior. This will allow you to avoid this nerve because it's not, of course, it's just a cutaneous nerve, but the patient after will complain of some abnormality of sensibility of the anterior part of the side. Keep in mind also that, of course, the number of MSc you can obtain is not only in relation with the anatomy, it's a relation with other factors. It's, of course, in relation with the disease, and you have some disease like corticosteroids or alcohol abuse that decrease the number of MSc. You cannot do, of course, anything for that because it's the cause of the pathology sometimes, but if you know that, you should increase the volume of aspiration. The age is also a point, but not so important, because you can consider that, of course, it's evident that a young patient has more MSc than an old patient, because you know that young patients have healing of the fractures very quickly, and the old patients need more time for healing fractures. But if you know some ideas of the influence of age, this may help you to get the aspiration. For example, I will say that this is the number of bone marrow nucleated cells in the iliac wing according to the age. So we can remark that the number of bone marrow nucleated cells decrease with age, but this is 100 years, and this is for 40 years, but not so much. The decrease is just between 45 millions and 20 million, so it's just decreased by 2 times. But as regard to the number of bone marrow nucleated cells, the number of MSc decrease more quickly. And if you look about these 200 patients between 18 years old and 100 years old, of course, you have a decrease. The decrease is in relation both with, of course, the bone marrow nucleated cells, but also with the probable function of the bone marrow and the possibility of the forming colonies for these patients is more difficult at higher age than younger age. But also, there is also an advantage. You can see that you have still MSc after 60, 80, or after 90 years old. It's not zero. It's keeps in mind it's around 500 MSc per milliliter. That means that you do an aspiration of, for example, 40, 50, 60, 100 cc of bone marrow you can take in the 2 iliac wings, and you do concentration after, you are able to get a level of MSc that will be around 2,000 per milliliter. So it's not impossible to do bone marrow aspiration in patients with older age. And we can remark, we have done that because we have the data for patients older than 80 years. So it's not a contraindication to do bone marrow aspiration in very old patients. You have just to keep in mind that the number is less, and of course you need to increase the volume of aspiration and after glucose concentration. You can also check is it how to predict. You have different way to predict. This is the same curve as previously. You see, and if you do a linear regression, it's, you can find that between the age of 25 and 80 years old, this is clearly most of your patients. It's more frequent indications is between 25 and 80 years. You can predict because it's a quite good linear regression between these 2 points. And it's very simple because the formula is 3,000 cells minus 30 multiplied by the age. That means that, for example, if you have a patient of 60 years old, it's 3,000, and 30 multiplied by 60 is 1,800. That means that you will have probably 1,200 MSC for these patients. And you can do the same for a patient of 40. So you can have a quick indication with this simple formula for patients between 25 and 80. But now if you do the linear regression and you continue down, that means that after 100 years, you go at minus number of MSC. Of course, this does not exist, of course, because if you have minus number of MSC, that means you are dead. So it's impossible. And you know that there are many patients older than 100 years that are still alive in Japan and in other countries. So that means that the linear regression is probably not the good curve, because if you have with this linear regression, you cannot live more than 100 years. So we test other curve, and probably one of the best is the exponential regression, but it's more sophisticated about mathematics. And one simple way, it's the logarithmic regression. And with the logarithmic regression, it's interesting because you can predict quite in a good way for young patients and for pediatric patients the number, because there are not so many data in pediatric patients, but if you use the logarithmic regression because it fits very well with the data, you can remark that a patient of 10 years at 4,000 MSC per milliliter, and patient of 1 year have, of course, a higher number. It's around 8,000 MSC per milliliter. But you can remark also that if you are 110 years old, you have still some MSC, so you are still alive. And so you can continue to live with some MSC. And it's not, even for this age, 300 MSC per milliliter is a correct number, because you can take 100 cc and you have 3,000 MSC, and you can concentrate them and inject. So it's quite useful. So keep in mind that you have different ways to get the MSC, about thinking about the anatomy, of course, about not only the anatomy, but the syringe, the force of aspiration, the age of the patient, and the pathology. So the first conclusion is that blood dilution should be avoided. That keep in mind the risk, and the higher risk of your aspiration is to get only blood and no MSC. And the first reason, if you have blood dilution, is using a large syringe and no force of aspiration. If you do that, you may have no MSC. And in my practice, sometimes you are looking with different residents how many MSC they are able to get. And when you test new residents, the ratio may be 10 times different between two residents, and sometimes more 20 times different between two residents if one knows how to do and the other one is performing for the first time. So you have to check And so it's for you the same. So at the beginning, takes time. Keep in mind, small syringe, high force of aspiration. So the volume of aspiration is necessarily limited if you want to get MSc. Keep in mind also the anatomy of the iliac wing. It's not difficult. The best way, if you begin, is to have a plastic iliac wing just in the room. You can see the anatomy, the shape, and it's easier to do the aspiration when you look at the plastic bone, and it's very simple. Think about the sector rules. It's very simple to keep in mind that for the anterior part, remain 2 centimeters back to the anterior iliac spine to avoid the femoral cutaneous nerve and to be able to get the cells. And if you want to go on the posterior part, keep in mind that remain the 5 centimeters for the depth of the needle. And of course, use several different sites of aspirations. Thank you for your attention, and I can answer to your questions.